Hi, good morning, everyone. I'm Dr. RASHMITHA SOMAGANI. Today, my topic of presentation is Adem, that is acute disseminated encephalomyelitis. So, as the name says, it is an acute condition and it's an encephalomyelitis. What do you mean by an encephalomyelitis? It is an inflammation of brain and meninges and myelin tissue. So, definition. So, ADEM is an immune mediated acute monophasic polyfocal demyelinating disease of the CNS. That is, a polyfocal disease is a disease which has multiple effects or a multiple neurological effects in a single event. For example, a monofocal has particular neurological manifestation, while a polyfocal lesion has multiple manifestations. So IPM SSG 2013 criteria. So basically, this IPM SSG 2030 criteria explained ADAM in pediatric population, but we are still using this for adult population as well. So they frame the criteria for the diagnosis of ADEM. That is, one, encephalopathy, which is unexplained by any fever or any other systemic illness, and two, polyfocal neurological deficits, and three, MRI showing diffuse poorly marginated T2 flare white matter lesions plus or minus gray plus or minus deep gray matter involvement. And this typically follows infection or vaccination 1 to 3 weeks prior. So let's discuss about the epidemiology. So incidence is 0.2 to 0.4 for 1 million children per year. So approximately 8 cases per million in entire population. And in pediatric group, the peak age of incidence is 5 to 8 years, while in adults, it's 30 to 40 years. And adults constitute only less than 10% of total cases. So the most ADEM cases, ADEM is most prevalent in children, but the mortality overall is less than 2% in children, while 7 to 8% in adults. That is, though the adult cases are less than 10%, 7 to 8% 8% mortality is seen in adults. And recovery is complete in 70 to 85% of children and only 45% in adults. So, and the ADAM shows slight winter predominance, usually a post-viral pattern. So, what is the pathogenesis? Pathogenesis is post-infectious molecular mimicry causing T cell and macrophage activation causing perivenous demyelination. So, the common triggers are non-specific viral upper respiratory tract infections, influenza, Epstein-Barr virus, mycoplasma, SARS-CoV-2, and there's a historic measles link to ADAM as well. So the post-vaccinal ADAM is less than 1 per million vaccines. So the risk is lower than the wild-type infection. And MOG IgG positive. So MOG IgG antibody is positive in up to 46% of pediatric ADAM. So the presence of MOG IgG predicts higher relapse risk and MOGAD continuum. If you are familiar with the MOGAD disease, ADAM is considered as a manifestation of a MOGAD disease. So MOGAD disease is primarily has positive MOG IgG antibody in up to 70 to 80% of cases. And MOGAD disease has higher relapse rates, recurrence rates, and much more severe when compared to ADAM. So usually, ADAM could be a primary manifestation of a MOGAD disease in pediatric population. So triggers and risk factors, as we discussed previously, the adenovirus and influenza, exanthematous viruses, measles, rubella, and varicella, bacterial mycoplasma pneumonia and Borrelia species, recent vaccines, Influenza, MMR, COVID-19, and biological agents, that is the checkpoint inhibitors, rarely cause ADEM. And younger age, that is less than 10 years, have higher susceptibility. Seasonal clustering, late winter to early spring, and there's no consistent sex predominance, but there's a slight male bias in kids. So, the clinical presentation of an ADEM disease. So, firstly, a febrile prodrome, headache, and vomiting is seen in almost 60 to 70% of cases. And encephalopathy, that is irritability, lethargy, eventually leading to coma, is present, and focal deficits such as hemiparesis, ataxia, or cranial nerve paralysis can be seen. And visual loss, that is optic neuritis, is seen in 15 to 20% of ADEM cases. Seizures can be seen in approximately 25%, and sensory loss or bladder function, these can only be seen if the lesion is involving a spinal cord. And usually rapid evolution to maximal deficits occurs within week of onset. So the MRI, classic MRI brain shows T2 and hyperintense T2 flare lesions. These are coolly marginated lesions, as you can see, and the size of the lesion is greater than 1 centimeter. So more than 1 centimeter lesion is a little massive lesion, and it is often confluent and gives a cloud-like appearance, and usually involving the deep gray nuclei, that is thalami and basal ganglia. So there is a patchy or an open ring gadolinium enhancement. And in spite of the size of the lesion, the mass effects are minimal. And diffusion restriction is uncommon, and hemorrhage is also rare in ADEM. So these lesions fade by 3 to 12 months, leaving subtle gliosis. So in MRI spinal cord features, you can see longitudinally extensive lesions. So how extensive? They involve more than or equal to 3 vertebral segments. So we classically call longitudinally extensive lesions involving central or dorsal coronum predominantly, and cord swelling during acute stage, patchy T1 post-contrast enhancement, as you can see here. This is pre-contrast and post-contrast enhancement, and often continuous with brainstem lesions. And this lesions fades dramatically after steroid therapy. So this helps distinguish from short segment MS lesions. Why? Because MS lesions on spinal cord are short segment lesions. That is, they involve the lesions, the, the length of the lesions usually, and on MRI and they are smaller in size, not as much as you see here, but they are very smaller in size. Next. And the distribution also I wanted to highlight here. In MRI of MS, you usually notice Dawson fingers, a pathognomic feature on MRI. Here, mostly a periventricular lesions are seen, while in MS, you see periventricular lesions, but smaller in size, and in callosal area, they are more predominant. Next, CSF and laboratory findings. Opening pressure is normal or mildly elevated. Lymphocytic pleocytosis, that which is you see in many kinds of meningitis cases. There's a lymphocytic pleocytis in 70% of cases. So it's first you need to differentiate from meningitis as well, and because protein is also mildly elevated in half of the patients, and glucose is usually normal. But oligoclonal bands, which are usually seen in 70 to 80% cases in MS, here they are negative in 70% cases. So absence of oligoclonal bands usually favors ADEM. And serum or CSF MOG IgG is positive in up to 46% in children in ADEM. And viral PCR and serology is negative in idiopathic cases. So differential diagnosis, I already talked about it, but again, multiple sclerosis is the number one differential diagnosis. It is relapsing. The classical Adam is a non-relapsing disease, while multiple sclerosis is a relapsing, and you will see periventricular callosal lesions and persistent oligoclonal bodies. And the other differential diagnosis is neuromyelitis optica spectrum disease, which classically has aquaporin P4 IgG positivity. So, neuromyelitis optica spectrum disease has optic nerve involvement, usually bilateral, very severe, and longitudinal cord involvement and area postrema lesions. And infectious autoimmune encephalitis, vasculitis, leukodystrophies, lymphoma, and a post-COVID Adam is increasingly being recognized, and so therefore to maintain a high suspicion is advised. So the treatment: admit to the neuro ICU if GCS is less than 8 or you see a brainstem signs, and IV methylprednisolone of 20 to 30 milligram per kg per day. Maximum of 1 gram is given over the period of 3 to 5 days. Switch to oral prednisolone, that is 1 to 2 milligrams per kg per day, gradually tapered over 4 to 6 weeks. And GI and venous thromboembolism prophylaxis is given during steroids therapy, and early physical, occupational, and speech therapy is advised. Seizure control with levetiracetam or valproate as needed, and we need to monitor electrolytes and blood sugar because of the steroid side effects. If the patient is not responding to steroids, IVIG 2 gram per kg over 2 to 5 days can be preferred, or plasma exchange approximately 5 to 7 sessions. And in case of fulminant cases, cyclophosphamide, rituximab, and mycophenolate can be used as rescue medication. So the prognosis, poor prognostic factors are usually the severe coma or spinal involvement, and age less than 2 years or greater than 40 years, and steroid non-responsivity, and diffuse brain edema. So as we discussed previously, children have 70 to 85% full recovery, and the residual deficit is only seen in 10 to 25%, and mortality is very less, that is less than 2%. While adults, according to Lee 2022 et al. Study, the full recovery is only seen in 45%, and residual deficit persists in 47% of cases, and mortality is very high, that is 7 to 8%. The complications. So, as I mentioned earlier, the monophasic Adem disease is a classic Adem disease, but sometimes it can be complicated into multiphasic Adem. That is a new episode which occurs more than or equal to 3 months later. So Adam, in monophasic Adam, there is a single attack in the first 3 months, and that is the first and the final attack. But in a multiphasic Adam, there will be a new episode after 3 months, and the risk of MOGAD with optic or spinal relapses. The Adam Adam could be a primary manifestation of MOGAD disease, and the optic and spinal relapses usually point to the MOGAD disease. Neuropsychological deficits will be present in children after Adam, that is like in attention and processing speed, and academic difficulties in approximately 25% of pediatric survivors is noticed, and MRI at 6 weeks has to be done, and also 6 months, and then yearly if there is anything atypical on the MRI. And vaccination is safe once acute phase of Adam disease resolves. So, and counsel for families on relapse warning signs so that they can get immediate medical attention, and encourage aerobic exercises and balanced nutrition. So the future directions of Adam disease. So the trials of early anti-CD20 in first event of MOG IgG positive Adam. Why? Because usually MOG IgG is an antibody which is secreted by B cells. So anti-CD20 treatment trials are being conducted. Example, rituximab trials are being conducted to see the effectiveness in the in MOG IgG positive Adem, and complement inhibitors such as eculizumab for formalin cases also being researched, and a high resolution myelin mapping MRI for outcome prediction, and serum neurofilament light as a surrogate marker in studies. Serum neurofilament light uh, uh, is being studied as a marker to tell the prognosis of the disease and relapse rates of the disease. And a global ADAM registry is initiated in 2024 to define or refine adult criteria. As so far, we do not have a adult criteria for ADEM disease. We are only using the pediatric criteria. So in 2024, a registry has been initiated to refine and define adult ADEM criteria. Thank you. That has been my presentation. Thank you so much.
Okay, thank you. So